Sorry, trying to redo it again. So can you see my screen? Okay, so I was talking of the complaints. You asked the patient, Mama brought you to the hospital this morning. She'll tell you whatever brought her to the hospital. Now, it says complaint is supposed to be arranged in chronological order, either ascending or descending. So let's say she comes in with, I'm just using any symptom because most pregnant women come in for regular routine antenatal visits. They don't really come in with any complaint, but I'll just formulate anything just to explain in case you get a patient that comes in with something. Let's say she comes in with headache of, you ask her how long has she been having the headache, and she tells you, okay, it started on Monday. Monday was how many days? 5 days ago. You write 5 days ago, and then she not say, oh, I've also been vomiting. And ask her, when did the vomiting start? She'll not tell you. It started on Wednesday. So Wednesday, let's say that's 3 days ago. You write it when they say chronological order, because the headache started before the vomiting. You write and you collect the headache before the vomiting. So you write the headache before the vomiting. Or let's just say she comes in with abdominal pain of how long? You ask her, how long have you been having this abdominal pain? She'll not tell you it started last month. So you not say a month duration. So the abdominal pain will come before the headache. So you write 1 month duration. So abdominal pain, headache, and then vomiting. Do you understand the chronological order thing?
Is it? Why would it come first before headache?
You say?
Why would the abdominal pain come before headache?
Because it started 1 month ago. Headache started 5 days ago.
Okay,
And vomiting
depending on
started
which
3 days ago.
Okay.
So the one that started first will come up first, followed by the next one, and then the next one. That's just complaints. That's how you arrange it. And then when you're now presenting it, you say, patients presented to our facility with, whenever she presented, okay, she came today, you say patient presented to our facility today with complaints of abdominal pain, 1 month duration, headache, 5 days duration, and vomit, 3 days duration. That's how you just say it. Now, for the history of complaints, you're now supposed to click this complaint. So she came in with abdominal pain. How do you click? You now ask her, ma'am, we use for pain, we use Socrates, Socrate. Socrates. When any patient come in with any pain, you can use this to click it and it to go. So you use Socrates. The S is site, the site of the pain. Now she said she came in with abdominal pain. You have to ask her where exactly is paining her. If it's everywhere in her abdomen, or if it's just the left part or the right part, just ask her where. Tell her to tell you exactly where it's paining you. So that's for the site. For the onset, you ask her, was the pain just sudden? Like, did you just come, or it was gradual? It started small, gradually. So that's for the onset. Then C is the character of the pain. Now, pain is dull, aching, sharp, or colicky. That's how was the pain dull? Was it sharp? Or was it colicky? The way a doctor explained colicky for me was, it's kind of funny. Did he hold you and then release, like grabbing your tummy and then it stops? That's how we explain colicky, and that's how I usually explain colicky pain for patients. Like Then radiation, R is radiation. You ask her, ma, when you ask her if when she's having this abdominal pain, does it go to any other part of her body? Like, does it radiate to her leg, to her back, to her chest? You ask her if the pain goes to any other side. That's for radiation. Then for A is aggravating factor. You ask her if the pain is being aggravated by anything. Like if she lies down, does the pain sorry, is the pain worse? Or if she stands up, is the pain worse? If she eats, is the pain worse? Shall I ask her what makes the pain worse? Then C is timing. You ask her what time of the day. In the morning, is the pain worse? In the afternoon, is the pain worse? Ask her what time of the day does the pain become worse? And then E is like R, exacerbating factor. That's what they call it. There's also something, if there's R can also be relieving factor. R can be radiating or relieving factor. The relieving factor, you ask her, does anything reduce the pain? Like maybe she'll tell you, oh, when I lie down this way, the pain relieves a little bit. So you ask her what relieves the pain. That's how you track pain. But for any other thing, I think there's this they call it the 5 C's. The first C is complaints. Then the second C is the cause, the SOURSE. Then the other C is the cause, the CAUSE. I can't see my screen again. I can't see the screen. Yep, I can see the screen sharing. The other C is complication, complication, and then the last C is care so far. So there are 5 C's. The first C is her complaints, what she came in with. Then the other C is the cause, the COURSE. The third C is the cause, CAUSE. The other C is the complication. Then the last C is the care so far. So when she comes, she gives you her complaints. Then the cause, you know, ask her, the cause is like the progress. Has it worsened or it has become better? Her complaint has become better. That's the progress. Has it become better or it has worsened? Then the cause is the etiology. You're trying to find out, okay, abdominal pain. You try to think, for a woman, what can cause abdominal pain? Just think of things that can cause abdominal pain.
Menstrual.
Yes, menstruation. Then there's uterine fibroid. When you guys start they'll teach you all these things. She can also be having, it can be anything in the abdomen that you think that can cause pain. It can be it. You can also ask her, has she had any trauma to her abdomen? Did she hit her tummy anywhere? Look for anything that you know that can cause abdominal pain. And then you try to click it, like rule it out. Like for menstruation, you ask her, ma, when last did you see your menstrual period? Okay, she's an obstetric patient. So you obviously she has given you her last menstrual period. You ask her, okay, did she eat anything? Maybe the food she ate sort of caused a stomach upset. So you try to look for things that you know that can cause abdominal pain, and then you rule it out. That's how you clear history of complaints. And then for fever, I think you use Odipara. You use Odipara, that's ODPARA. O is onset, D is duration of the fever, P is progression, A is aggravating factor, R is relieving factor, then A is associated symptoms, like other symptoms are associated with the fever. So there are some things that there are basic pain, fever, and then there are other common general complaints that you have mnemonics. Well, if you use if you check principles, and then there's another one, the guide, they have how to check. And then on the websites, I've already given, on the websites, there'll be files that I've given for them to put on the website, so that you can see how some common cases in obstetric, the woman, most women come with routine antenatal visit, so she usually does not have any complaints, and all you just have to say is she presented to our facility this morning for her routine antenatal visits and has no complaints. That's all you just have to say. So the next thing you just need to go to is booking history. Now, for the booking history, remember I told you at the beginning, she must have told you if she has booked or she has not booked. Now, in the booking history, you have to now ask her if her pregnancy was spontaneously conceived or it was assisted. Now, for spontaneous, that means she didn't use any, there was no technique. Her and her husband just had sex and then she got pregnant. But if it was assisted, she'll probably tell you she did an IVF or any of all these assisted techniques that they use for people who can get pregnant. So you ask her if it was spontaneously conceived or she was helped to conceive. That's called assisted. Now you now ask her if it was planned or it was not planned. Now, planned is that they actually planned, they were planning that they wanted to get pregnant, so they worked towards it. But unplanned, she just left with her husband. Maybe she don't use protection and then she got pregnant. Now, you have to ask her if she desired the pregnancy or she did not desire. You know, some people get pregnant and it was not what they actually desired. Some people planned it and some people did not plan it, but still they still desire their pregnancy. So you still have to ask the patient if she desired the pregnancy or she did not desire it. Now, you have to ask her how she suspected and confirmed the pregnancy. It's very important. So some of them will say they suspected they were pregnant. Probably they were having nausea and vomiting. Some will say they missed their period. They can tell you how they suspected it. And then you have to ask them how they actually confirmed that they were pregnant. Missed period does not confirm pregnancy. A missed period cannot confirm pregnancy. That she's vomiting or she's having nausea does not confirm that she's pregnant. So you now have to ask her, how did she actually confirm that she was pregnant? She might tell you, oh, I got a pregnancy kit in the pharmacy and I did a urine test with it and it told me I was pregnant. Or she might tell you, oh, I came to the hospital and they did a blood test for me and confirmed I was pregnant. Or she will tell you she did an ultrasound scan and it confirmed that she was actually pregnant. So whatever means she used to confirm, you have to state the means at which she confirmed that she was pregnant. Now, for the where is where she booked her pregnancy. If she tells you that she's booked, you have to ask her where she booked, what hospital. She might have booked in your facility or she not booked in your facility. So she'll tell you where and then when. The when is at what gestational age did she book her pregnancy. You might say, oh, I booked my pregnancy when I was 8 weeks. You actually hardly find people who come as early as 8 weeks to come and book their pregnancy. But whatever week she tells you that she booked her pregnancy, you write it. She booked at a gestational age of maybe she was 10 weeks, she was 26 weeks. Some people even wait till they are like 30-something weeks before they come to book their pregnancy. So whatever week she tells you, you write it down. Then how many visits has she had? Now, the traditional antenatal care visits usually before she's 28 weeks, she's supposed to have a spacing of 4 weeks before she's 28 weeks pregnant. Let's say she comes this week. The next time she's supposed to come is after 4 weeks. Now, when she now gets to 36 weeks, from 28 to 36 weeks, she's supposed to be coming to the hospital every 2 weeks. So she comes today, the next time you're supposed to see her in the hospital is 2 weeks. Then from 36 weeks, she's supposed to start coming every week to the hospital for visits. But then it depends on when she booked. You know, ask her, how many times have you come? Some of them don't remember. So what I do is, if she says she booked at 28 week or whatever week she booked, I'll now help her calculate it. Okay, if she was 30 weeks, I know that at least if she booked at 30 weeks, I know that the next time they're supposed to give her an appointment is in 2 weeks. So I calculate. So from 30 to 36 weeks, she's supposed to have had 32, 34, 36, 3 visits. Now, depending on when she came to when I'm seeing her or when I'm checking her, so I just use my head to actually calculate it, because some of them they will not be keeping tabs of how many times they come to the hospital. So I just use my head to calculate for them, especially if your patient is judicious with coming to the hospital for antenatal care. So I use my head to calculate it depending on the day she. Do you understand?
Yes.
So IPT is called intermittent preventive therapy. I'm sorry for the abbreviation. You're not supposed to be using abbreviation, because if you tell them IPT, they'll mark you down for it. So you're supposed to tell them intermittent preventive therapy. Now, this IPT, intermittent preventive therapy, is for malaria. Now, for a pregnant woman, you're supposed to, because we're in a malaria endemic region, you're supposed to treat them prophylactically, for malaria. And you're supposed to begin this treatment when she perceives quickening. And quickening means perception of fetal movements. When she has perceived fetal movements, usually it's supposed to be 16 weeks of gestational age. But then if she has not perceived quickening, some textbooks say it's safe to start giving her IPT, intermittent preventive therapy for malaria, at second trimester. And first trimester is 1 to 13 weeks. Second trimester is from 8 to 28 weeks. So you can start from 14 to 28 weeks. So you can start giving her this thing at second trimester. But usually they say when she perceives quickening, and a woman is supposed to have perceived fetal quickening at 16 weeks. And now they say you should start giving this when she has perceived quickening, because it means that the baby has fully developed, like the embryological development has been sort of completed. Because if you give it before then, the IPT they give is sulfur containing, and it can cause it can be a source of teratogen, and then it can cause fetal malformation. So you don't want to give it when there's still embryological development going on. So you want to give it when she has perceived that quickening. That's why you give it. Now, TT is tetanus toxoid. For every woman that is pregnant, you are giving her tetanus toxoid. It's not for her. It's to prevent neonatal tetanus. I think they'll teach you that in pediatrics. They're supposed to teach you tetanus in pediatrics. So you're preventing the child from having tetanus. It's not the mother. You're not giving the mother the TT for her, but for the child. So every patient is supposed to have 5 doses of tetanus toxoid. The first dose is given at contact. That's the first day you meet her, and then probably she has not had anyone. You give her that day. The second dose is supposed to be given 4 weeks later. The third dose is supposed to be given 6 months after the second dose. The fourth dose is supposed to be given 1 year after the third dose, and the fifth dose is supposed to be given 1 year after the fourth dose. Now, each of these doses confer an immunity. They usually ask, by the time they ask you how many doses and when do you give this, when do you give each of the doses, and you say, oh, you give the first dose at 0, 4, 6, 1, 1. Now, the next thing that the doctor would likely ask you is, what immunity does each of them confer? For the first dose, it confers no immunity at all. It confers no immunity. The second dose confers 1 year of immunity. The third dose confers 3 years of immunity. The fourth dose confers 5 years of immunity. And the last one is lifelong. So the way I say it is, so 0, 4, 6, 1, 1, that's when you give the dose. Now the immunity confers is 0, 1, 3, 5, then lifelong. Now, but they can now ask you, after you say lifelong, they can ask you, okay, when next can you give another dose of it? Usually they say after, when you've given the last dose, remember I said it confers lifelong immunity. They still say you can give another one 5 to 10 years after the first dose. Or if the patient comes in with an injury, even if she has had the whole 5 doses of tetanus toxoid, you can still give her a dose, a booster dose. They call it booster dose. When do you give booster dose? Either you give her 5 to 10 years after she has completed the whole dose, or you can give her when she comes in with an injury. So you ask her how many. Some of them come in and they've probably finished like the first 3 doses in their previous pregnancy, or it's expected that, depending on when she books, it's expected that at least she must have taken the first 2 doses of tetanus toxoid in one pregnancy. So, but just ask her how many she might have. She can tell you, oh, I took some like when I was pregnant in my previous pregnancies. But just ask her how many doses of tetanus toxoid has she taken. She'll tell you. Then you ask her how many ultrasound scan has she done. She'll tell you the ultrasound scan. Now, some doctors will just tell me the information of the recent one, but some doctors too say, tell me the result of each of. Most of them I don't really know the result of the ultrasound scan, but you can ask her, what did the doctor tell you? Was it normal or it was not normal? You say it was normal. Now, the last thing, for the intermittent preventive therapy, the tetanus toxoid, and for the ultrasound scan, you ask her at what gestational age did she take the drugs, and at what gestational age did she do her ultrasound. Some of them don't remember. They will not really penalize you for it, but make sure that you ask, because they will ask you, did you ask? And they will ask your patient, did she ask you? So you try to ask. There's another thing that was omitted in this, and that's routine drugs. For pregnant women, there are 4 routine drugs they usually give them. That's folic acid, vitamin B complex, vitamin C, and ferrous. So you ask her, ma, do you take routine, like you ask her what routine drugs she's on. Don't just assume she's supposed to be on this for, because some of them don't take it. And then there's this Well Woman pack that contains the 4 drugs in one tablet. So some of them take that one. So you ask her, ma, what routine drugs do you take? She'll now tell you, oh, I take folic acid, I take ferrous, I take vitamin B complex, I take vitamin C. So you ask her what routine antenatal drugs she take. Now, after booking history, you move on to her past obstetric history. And past obstetric history, you just want to find out about her previous pregnancy. Now, if she says she has been pregnant for 2 times, you ask her, okay, usually not really delivery dates. Nobody really care about the dates, but just ask her, what year did you have your first pregnancy? She'll probably tell you, oh, 2005. You ask her, was it male or female? She'll tell you. If she can remember the weights, most of them remember the weights of their babies. She'll tell you. APGAR score, they don't usually remember the APGAR score, but what we usually use to ask for APGAR score is if the child cried at birth. It means that if the child cried at birth, it means that the APGAR score was good. That's what we use in obstetric. But in pediatrics, they'll teach you what APGAR score is very well, and you're supposed to know everything about APGAR score. So that's not my duty. When you get to pediatrics, they'll teach you APGAR score very well, and you know all the components of the APGAR score and what score each of them carry. So you ask, after you ask for the APGAR score, you ask during the pregnancy and the delivery, and then after the delivery, was there anything serious happen? Like you ask her, whether there was a complication with the pregnancy. So if there was no complication with the pregnancy, you just say pregnancy, delivery, and puerperium were not adversely eventful. That means there was no serious thing that happened. It was just normal pregnancy, normal delivery, normal puerperium is the period from delivery, after delivery to 6 weeks. That's what they call puerperium. So if nothing happened within this period, they say they were adversely uneventful. Then you now ask if her child has been immunized according to the National Program for Immunization. Now that's always saying, it's always good to use swoosh and good terms, National Program for Immunization. I remember during one ward round, and we said, oh, the child is fully immunized according to the National Program for Immunization schedule. And then the next thing the doctor was asking, what is the National Program for? I mean, the way I went was like, sir, this is O&G, this is not pediatrics, because it's usually in pediatrics that they ask you immunization schedule for children. It's not in O&G. So whether you're in O&G or you're in pediatrics, it's just important for you to know the schedules because, I mean, it can be a question they can ask you. Then for the educational status, you just ask if the child is well and alive, if the child is doing well in school, and if the child is still alive. So usually the way we report it is first confinement, we call it confinement, first pregnancy. You can say first pregnancy, but you can decide to be tush. Say first pregnancy was in 2005. She was delivered of a live male neonate via, you need to ask through what procedure, whether it was vaginal delivery or it was cesarean section. Cesarean section. Sorry, that's not part of the listing, but when I remember, some of these things are already at the tip of our finger. So you say she was delivered of a live male neonate via spontaneous vaginal delivery, or you say via cesarean section with weight of, let's say, 2.8 kg. Child cried well at birth and was breastfed. You also need to say if the child was breastfed or not. That also I omitted, I'm sorry. So you need to say if the child was breastfed. So you say cried well at birth and was breastfed. Child is adequately immunized according to the National Program of Immunization Schedule. Child is well and alive. For the whole present state of the child, you just say if the child is well and alive. Child is well and alive. Pregnancy, delivery, and prepucium were adversely uneventful. You need to tell them if there was an event or not. So that's all for past obstetric history. So do you understand up to this level?
Yes, but I just want to ask for the 4 routine drugs. What was the last one you mentioned?
Okay, I said folic acid, vitamin B complex, vitamin C, and ferrous.
Ferrous, that's iron. Okay.
Yes.
Okay.
Okay, so moving on to the gynae history. For the gynecological history, now the menarche is the age at first menses. You're asking her, Ma, when did you attain menarche? If it's a gynecological patient and maybe she's very old, she might not remember when she attained menarche, but they will usually tell you, try to help the patient to remember. You ask her, Ma, do you think you were in secondary school, maybe you were 13, you try to, if she says she cannot remember, so I try to prompt her, say, do you think you were 13, you were this old, maybe you were in secondary school, were you like 15 or 13 years? She'll try to say something to make them come up with an age. If it's an exam, the patient must try to remember her first this thing because it's important, especially for both patients. It's important that they remember their menarche. So try, because they will ask you what questions do you ask her. So you can ask her, when you're in secondary school, when you're in primary school, just try to look for things you can use to try to make her remember. Now, catamenia, like they said, is designated as K. So you're asking her cycle length. You ask her how many days does she how many days is her cycle length. Some of them don't even know. They'll just probably tell you 28 days because everybody believes that 28 days should be the normal one. But yeah, it's between 20 to 35 days. That's the normal cycle length. But then she might tell you she doesn't know. Just tell her, Ma, do you think it's 28, 29, 30? Try to make them remember. So some of them will just go straight and tell you they menstruate. Their menstrual cycle length is 28 days. Now you ask her how many days does she menstruate for? Is it 3 days, 2 days, 5 days, 4 days, 6 days, 7 days? They will tell you how many days they menstruate for. Then you now ask her if it's regular. Some people's cycle menstruation might not be regular. They might see this month, they will not see next month. They might not even see the next 2 months. Then they will not see it. So you ask her if it's regular, if it comes every month. Then you ask her the rate of the flow. Is it heavy? Is it very heavy? Is it normal or is very light? So you ask her, that's rate of flow. Then you ask her if she has pain during the flow, that's dysmenorrhea. Then you ask her for dyspareunia. Dyspareunia is called pain while having sex. You ask her if she has pain during sex. Then you ask her for menorrhagia. Menorrhagia is designated as either flow, she's menstruating for more than 8 days and her flow is very heavy. That's menorrhagia. So you ask her if she has menorrhagia. Then that's all about, no, that's not all about gynae history. Then the next thing you need to ask her is if she's aware of contraception and if she uses it. Now, some of them may tell you that, oh, they know of contraception, but they don't use contraception. Now, when they tell you they don't use contraception, ask her, ma, does your husband use condom when having sex, when you people are having sex? She'll tell you, oh, yes, my husband uses condom. So when they ask you about contraception, you say, patient is aware of contraception, but does not use any, but her husband uses condom while having sex. I mean, when they have sex, you need to state that the husband uses condom. Now, pap smear. Now, pap smear is a screening technique that they use for cervical cancer to detect the pre-malignant state of cervical cancer. It's called cervical intraepithelial neoplasia. That's the pre-malignant lesion before cervical cancer comes. So some patients don't know of pap smear. So you ask her, ma, have you done pap smear? She might ask you what is pap smear. You now have to describe it. They usually use a swab to take sample. They'll do a bimanual speculum examination, and then they'll open her vagina with a speculum. When you get to ONG, they'll show you all these things, and you probably see them or get to see a doctor do it. And then they'll use a swab. It's like it's like that swab that you use for when they were doing testing for us for COVID. It's like a cotton board, very long one. So they use it to swab her cervix and then to send it for cytology to check if she has the CIN. That's the cervical intraepithelial neoplasia. Then you ask her for history of miscarriage. Now, when you say miscarriage, some of them ask her, ma, have you had any abortion? Because some of them will tell you, no, I've not had any miscarriage. Ask her, ma, because miscarriage and abortion, they are synonyms, they are terms used together. They are not separate, they are the same terms. But you know, in our, like the doctors will say, we put it as miscarriage so that patients don't feel bad that they had an abortion or something, but it's called abortion. Ask her, ma, have you had any abortion? Whether it was, they usually call it VTOP or STOP. VTOP is voluntary termination of pregnancy. STOP is spontaneous termination of pregnancy. So you ask her, ma, have you had any voluntary or spontaneous termination of pregnancy? If she has had, she'll tell you. Then you need to, she'll not tell you, ask her at what gestational age. She'll tell you, even the kind, you ask her what technique, whether it was a manual vacuum aspiration or whatever technique that they used to remove the product of conception. Just ask her what technique. The MVA is like a syringe that they used to suck out the product of conception from the uterus. Still sorry, when you get to when you start ONG fully, they'll show you guys all these things, but they might seem vague. So that's all for gynae history. Do you understand the gynae history?
Yes.
Thank you. Now for the medical and surgical history, yeah, you are just basically asking the patient. There's also the mnemonic we use, SHADE, or you call it SHADE. Some people have SHADE P, or you say P SHADE, anything you want to use. People have different ways that they used to, you know, so that they can remember. So you ask her if she has, the S is sickle cell disease or seizure disorder. Then the H is hypertension. The A is asthma. The D is diabetes. The E is still epilepsy. Epilepsy and seizure disorder are the same thing. So by the time I ask seizure disorder, I don't ask epilepsy again. Then you now ask for P, peptic ulcer disease. And then you can ask for renal disease too, if the patient has. So that's what you ask. The patient may tell you, I don't have any of this. Oh, she tell you, oh, I have ulcer, or I have this. So you have to state, oh, patient is a known diabetic, hypertensive, sickle cell disease patient, renal disease patient, seizure disorder, patient is a known asthmatic patient, or patient is not a known seizure disorder patient, sickle cell disease, hypertensive, diabetic, asthmatic, and everybody. You just have to mention all of it. Then previous history of surgery. You have to ask her if she has had any surgery before. If she has had, you ask her when, the reason why she had the surgery, the outcome, if there was an adverse outcome or there was none. Then you ask her if she has ever had any blood transfusion. You ask her when too, the reason she had the blood transfusion, and then how many pints of blood was she transfused. All those things are important. That's all for medical and past medical and surgical history. Then the next thing is family, social, and drug history. Now for the family history, you're asking her if she's married or not. From the beginning, you must have asked her if she's from your biodata, you must have asked her if she's married, because she will tell you, you need to state if she's a Mrs. or a Miss. So you now ask her if she's married in a monogamous setting or polygamous setting. Most of them might not really understand these things. Like we that are here at Kiko, most of these women are like, they are old women. So some of them don't understand these terms. So you just say, are you the only wife of your husband? Or are there, how many wives are you? So by the time you use layman terms, she will understand. So you know if it's a monogamous or a polygamous setting. Then you ask her if, before the family history of things, you ask her husband, the age of her husband, the occupation he does, and his educational status. The education is highest level of education. She might tell you, oh, he has BSc in computer science, or he has HND, or his highest level of education is secondary school certificates, that's SSCE. Then you also, at this point, you also ask the patient her own highest level of education. So she tells you her highest level of education. Then you can now go ahead to now ask for family history of disease or allergies. Now, the family history of disease, you also see asking the same, sickle cell disease, hypertension, asthma, DM, epilepsy, and all those. You're still asking the same if there's family history. And then for in an obstetric patient, you can ask for family history of twinning. So some doctors, when you note family history of twinning, is like bonus mark for the candidates. Then you need to ask the patient if she smokes, if she takes alcohol. Now some of them might tell you they don't take alcohol. You can ask them if they take palm wine too. Ask her if she's on any routine drug. Like if a patient is hypertensive, she would definitely be on antihypertensive. So, but then if she's hypertensive, you must have stated at the medical history, patient is a known hypertensive patient, diagnosed. You asked her when she was diagnosed hypertensive. Then, yes, also one thing for peptic ulcer disease patients, some people might just come and tell you that they have ulcer. If it was not diagnosed endoscopically, she's not diagnosed, she's not a diagnosed peptic ulcer disease patient. They will always ask you, was it diagnosed? Was it confirmed endoscopically? So if it was not confirmed, you just say patient is a known peptic ulcer disease, but not diagnosed, not confirmed endoscopically, and all that. So for a hypertensive patient, I'm sorry, I'm going back. You say patient is a known hypertensive patient, diagnosed what here, and she's on tabs, nifedipine, labetalol, whatever drug she's using for her hypertension. You state some doctors can go ahead to ask you what dose of drug does she use. So you ask the patient. Some of the patients know the doses of whatever drug they take, or you ask them. If they don't know, you ask them, did you come with the drug? So you check. They usually write the dose on the pack of the drug, so you can check. So back to the family, social, and drug history. You ask the patient if she takes alcohol, she smokes, she uses drug, both pharmaceutical or hard drug. Ask her if she takes herbal concussion, and ask her if she's allergic to any drug too. So that's about it. Then for the systemic review, you're just basically trying to check other systems that you not probably look at in your main history. So let me say she comes with the example we use, abdominal pain. In abdominal, you must have ruled out every other abdominal symptom, nausea, vomiting, so you don't need to go back to it. So how we do it, we usually start from head. For CNS, the central nervous system, usually asks, do you have headache? Do you have photophobia? That's if she looks at the lights. Usually say, ma, if you look at this light now, does your eye pain you? She'll tell you no, she does not have any photophobia. Those are usually the basic question I ask for CNS. Then for the CVS, that's cardiovascular system, yes. Do you have chest pain? What other things do I use for CVS?